Got 2 o'clock, so we'll give it just one more minute and then we'll get our maternal webinar series for this afternoon started.
Oh, we were the first ones.
Oh, yeah, the thing we tried, yeah, last week or
All right, I've got 2:01, so we're going to go ahead and get started this afternoon. Thank you for joining us this afternoon. This is our May Georgia PQC maternal webinar titled Quality Improvement Using the Lens of Equity. Before we get started, just a few housekeeping items. Please make sure to mute your line during the webinar to avoid any interruptions. This webinar and past webinars are housed on the Georgia PQC website for sharing and going back to review at your convenience. They're located under the Maternal tab. We should have a few minutes for questions at the end of the presentation. Feel free to type any questions into the chat. If for some reason we run out of time and you have a question, feel free to email that to us at georgiapqc@dph.ga.gov and we will get back to you. The Georgia Perinatal Quality Collaborative, as you know, is Georgia PQC, launched in 2012 with a vision for better perinatal outcomes and health equity for every Georgia mother and baby. This was in response to the fact that for years, being born in Georgia has been a risk factor for overall health, with Georgia ranked at the bottom nationally for maternal mortality and for many infant health factors. The Georgia PQC's mission is to engage stakeholders in implementing equitable, evidence-based perinatal care through a robust, data-driven quality improvement collaborative. At Georgia PQC initiatives, we focus on addressing the social drivers of health and improving health equity in maternal and neonatal care. Georgia PQC just completed our annual conference on April the 25th and 26th, and the title was The Next Generation. A huge thank you to everyone who made this conference possible. It was very successful. Registration sold out this year with 119 in-person attendees at the conference. We were blessed with great speakers, time for networking with others, and a call to action to continue the work to improve maternal and infant morbidity and mortality in Georgia through quality improvement and collaborative work. So again, thank you for all for what you do every day. Just some information sharing before we jump into our webinar today. First, we wanted to share the lineup of webinars and speakers through this year. The webinars were set up based on feedback you all provided to us from the implementation survey completed back in December. So know that when you share information, we try hard to listen and provide tools and resources that can be helpful to the work and the initiatives you are doing. And thank you for your willingness to always share our survey and provide feedback so that we can help meet you all where you are in this work. We look forward to your participation on the webinars. Feel free to share the flyers and links with colleagues and partners who may benefit from this information. As our team at GAP grows and transitions, we want to make sure you have had the opportunity to meet Jennifer Bowen. Many of you know Jennifer from her previous role as the maternal outreach educator for Atrium Health Navicent in Macon, Georgia. She brings a wealth of experience regarding maternal bundle implementation across all levels of care. Jane Reed has been serving in this capacity and will support Jennifer as this transition takes place. I'm going to turn it over to Jennifer to let her tell you a little bit about herself and her new role. Jennifer, we can't hear you. I think you're on mute.
Can you hear me now?
Yes, ma'am. Thank you.
Sorry. I'm Jennifer Boland. I served as the maternal outreach coordinator in Macon. For about 6 years, I've worked in labor and delivery for about 18 years, and I worked in the neonatal intensive care nursery for about a year and a half prior to that. And so I recently took the position as the Women's Clinical Health Liaison with DPH. And so I'm going to have kind of a dual role there. So part of that, I will be, supporting the regional perinatal system in Georgia. I'll be, there for support for our RPC outreach educators, as well as the medical directors. But for you, as part of the GAP QC hospitals, I'll be here to be your quality improvement advisor. So I'll be able to help assist you with your PDSAs. Hopefully we'll get some coaching calls underway soon, and just help work collaboratively with the hospitals that are involved in GAP QC to help steer their QI initiatives. Offer support to all of their GAP QC hospitals with their data submission. Also, we do have a new data submission program coming up that I know Amy's going to mention in the next couple of slides and talk to you about that. So I'm really excited about that, and hopefully we'll be able to do some one-on-one coaching with that as well. And then just some contact information for me is there on the slide as well. So that's my office number, that's my email. So please, feel free to reach out to me when you need, and be listening out or looking for some emails from me so that I can contact you to go ahead and get some of those coaching calls and meetings underway.
Thank you, Jennifer, and we're so excited to have you on board. And she's already started transitioning and making a huge impact on the work that we're doing. So grateful for Jennifer.
Thank you.
So you spoke, we heard, and we listened. We're very happy to announce that GAP Maternal Initiatives will be transitioning to a new data platform called Simple QI. Simple QI is a secure, cloud-based QI constructed platform built to accelerate improvement work through collaboration and shared learning. We anticipate conducting training on the platform later in May with several active facilities piloting the platform with the expectation that all active facilities will be able to submit Q2 2024 data into the new system. And we've got more information that will be coming in the next few weeks related to Simple QI. So we're very excited to be transitioning to this. Code for Georgia Moms, North Georgia Health System Center for Simulation and Innovation, and A1 are teaming together to provide OPS training. There are multiple dates scheduled. This is a wonderful opportunity to enhance skills in managing OB emergencies through simulations and debriefing. The training aims to equip clinicians with the knowledge and techniques to effectively identify, assess, and manage patients in critical situations. If you or someone from your facility would benefit from this training, please reach out to Tasha at the email address on the screen. This is a wonderful opportunity supported by the HHS grant received by North Georgia Health System. And I don't know if Bridget or anyone from her team are on the call today, but if you have any additional information to share about this, feel free to come off mute.
Hey, yeah, no, just we really wanted to give opportunities for people to take the obstetric patient safety OB emergency workshop. So we encourage people from different regions as well as OB and any ED partners that you have. So yeah, just reach out. We would love to have you come and then maybe even become an instructor and just share it throughout the state.
Thank you, Bridget. Just a few other maternal updates we wanted to share. Our next GAP maternal webinar is scheduled for Tuesday, June the 4th at 2 p.m. And our guest speaker for that webinar will be Dr. Stephanie Radke from the University of Iowa. She will talk about getting back to the basics with quality improvement work. The next AIM-TAP webinar is scheduled for June the 20th and is titled Reducing Perinatal Inequities Through Black Feminism and a Radical Imagination. This was part of the Black Maternal Health Week in April. The next Maternal Health Echoes are scheduled for tomorrow, May the 15th, and August the 21st, and will feature Hope for Georgia Moms, Impacting the Maternal Health Crisis, and Cardio OB, Addressing Cardiac Health for Women with CSRA. We all know that data is essential for conducting quality improvement work. Please see the dates for quarterly data submissions. Just to note that we are always happy to accept back data if you can provide it. Additionally, if you do not have the capacity to submit data on a quarterly basis, please submit data at least annually. If you have data-related questions, please do not hesitate to contact someone at GAP for assistance. If we do not have the answer directly, we'll make sure to connect you with our EPI team who can provide the answers you need. For those actively submitting data, your Quarter 3 2023 hospital data reports were released on April the 10th, and the Quarter 4 2023 hospital data reports were released on April the 20th. They are available on Microsoft Teams in your individual hospital folders. Hemorrhage and hypertension are housed in separate files from the cardiac reports. Again, please let us know if you need any help reaching those folders or if you have any needs in getting your unique identifier. And thank you to all who submit your data to us on a regular basis. We're thrilled to partner with Georgia Maternal Task Force to support a symposium and call to action in which Dr. Hamid from California will speak. This is still in the planning stages, so there's more to come on this in the near future. And as we know, collaboration is ongoing with the Georgia Chapter ACC and the Medical Association of Georgia to develop a comprehensive cardiac referral network. These two things we did share at the annual conference, so you may have already seen those before. These participating cardiologists have agreed to see pregnant and postpartum people who have been screened and identified to have a cardiac condition for which follow-up is indicated. This is an ongoing project, and so there's still more work to be done on this, so stay tuned as this project continues to evolve. And just an update, we currently have 16 actively participating hospitals located within 5 of the 6 perinatal regions. We are actively recruiting for Wave 2 of the Cardiac Conditions and Obstetric Care Initiative and would love to have you and your facility join us in this work. If you're interested in joining as part of the Wave 2 recruitment, please reach out to me, Amy Mock, to get signed up. Or you can complete the enrollment form online from our website using the link on the screen. It's Georgia, spelled out, pqc.org. The goal is to have at least 28 actively participating hospitals by 2027. And finally, just some opportunities and resources that we want to share with you all. Whether you're just starting out on this journey or you've been working in QI for years, this series of webinars created by the Institute for Healthcare Improvement and AIM will support your teams to effectively implement bundle implementation. These actionable change packages align with each AIM patient safety bundle. The links to the 4 series webinars can be found on our website, again at georgiapqc.org, as shown on the slide. GAP recently updated some of our educational materials as well as added Spanish versions of the Peach poster, magnet, and the business card is currently in the works. All of the educational materials are free for download. You can also co-brand them and place your facility logo on them. If you would like to order any of these materials for your facility, you can visit our website and the vendor is listed directly above the materials. You can order as many as you like and the vendor will drop ship them directly to you. The QR code on the slide takes you directly to the materials on our website. And a special thank you to our cardiac work group and education subcommittees for all the work in creating these materials. AIM recently revised their SMM review form and developed resources to support inpatient chart reviews for SMM. They're planning an AIM SMM review form learning sprint in August, but please stay tuned for more information on this. AIM also updated their patient safety bundle learning modules. Each course features a comprehensive overview of an AIM patient safety bundle and its key elements. The modules are a great way to get your clinicians, providers, and staff educated on hypertension, hemorrhage, and cardiac conditions in obstetric care as a way to meet process measures 3 and 5 related to training and education. Currently, you can earn a certificate of completion through ACOG's LMS system. However, if your hospital has access to HealthStream as their learning management system, you can find the modules there and you can earn CME or CE credits through their platform. AIM's working to provide public links so everyone can earn CME and CE credits. We're being told that HealthStream should be able to provide a quarterly report of people by facility who have completed the training. So more to come on this. For those of you working to engage your emergency departments in the work to ID and screen pregnant and postpartum women, there is an AIM Obstetric Emergency Readiness Resource Kit, and the link to this resource is listed here on the slide. Before we introduce our speaker today, we just want to remind you of why we're here and what helps drive the work we're doing. The AIM bundle components are the 5 R's that lead our key driver diagram. You can see those here. Most of you have seen this slide many, many times. We always like to share our key driver diagram for maternal cardiac conditions, which show the goal to reduce severe morbidity and mortality related to maternal cardiac conditions in Georgia, and our SMART aim by February 6, 2026 to reduce harm related to existing and pregnancy-related cardiac conditions through the 4th trimester by 20%. And the interventions and processes can be seen here with the small orange S1, S2, so forth. As we support hospitals with bundle implementation, we want to call out the importance of the readiness and recognition in particular, especially establishing a multidisciplinary cardiac OB team and appropriate screening and referral for pregnant and postpartum people. It's impossible to implement this bundle as siloed clinicians. It is essential to work together to improve the structures that impact access and utilization of care. Here are the PCOC process measures that are linked to the readiness and recognition learning key driver. Structure measures 1 and 2 can be found within the readiness and recognition key drivers. The remainder of the structure measures fall within response and reporting system learning. These are first steps in moving efforts forward in your facility. And all of this work has been done with the 5th R, which is respectful care. So today, I'm honored to introduce our speaker, Rose Horton, who will present on quality improvement using the lens of equity. Rose Horton is the founder and CEO of Not on My Watch Consulting Partners, LLC. She created her company out of her frustration at the rising rate of maternal morbidity and mortality. Her hashtag, Not on My Watch, became a call to action for her fellow nurses as one of the largest healthcare employers, to use their collective voices to support, listen to, advocate for, and follow evidence-based practices in caring for all birthing people. Rose's background includes working as a labor and delivery staff nurse, high-risk OB flight nurse, and several leadership opportunities in diverse healthcare settings. She's a member of A1 and is serving as the 2024 president-elect. She's currently a board director for Sonova Associates, Medela, Count the Kicks Healthy Birthday Incorporated, as well as the National Network of Perinatal Quality Collaborative. In 2021, Rose was invited to serve on the Biden administration's Black Maternal Health Stakeholder Group. Please help me welcome Rose Horton. Thank you, Rose, for presenting today, and now I'm going to turn it over to you.
Thank you so much, Amy, and I'm going to go ahead and get started. And I just need to make sure that you can see just one slide.
Yes.
Perfect. Thank you. Welcome, everyone. And I'm excited to be here to speak on this topic, which I think is extremely apropos for GAP QC, right? That's what we talk about, QI tools and QI measures. And I just want to talk to you for a few minutes about the importance of ensuring that we're using an equity lens in our work. So here are our objectives, and we're going to level set by having conversations about what's our current reality. And I know many of you know this, but it's important for me to make sure that we're all on the same page. So Dr. Vidam did her study that was published in 2019, Giving Voice to Mothers. And a small statement that really resonated with me is that global health experts agree that how we treat people during childbirth, just a defined period of time, affects the well-being of mom, of the baby, of the family, AKA everyone. So it's important for us to consider that. And these were the findings. They sent out 20,000 surveys. 2,138 responses came back, and 1 in 6 women said that they were mistreated during labor. This is 2019. And you can see here on the screen, I'm sure this is not new to many of you at all, but birthing people and women complained about being shouted at, being scolded, violation of their privacy and confidentiality, not having autonomy. They talked about coercion, and that was in 2019. And it's interesting to note that CDC repeated this in September of 2023. And so our data went from 1 in 6 to 1 in 5. So we're definitely not moving in the right direction. We're moving in the wrong direction. We already know that as we talk about maternal morbidity and mortality, that there's disparities that are noted, and that Black and Brown women are 3 to 4 times more likely to die. So that's all part of the level setting about why is it important to weave in equity in our conversation. So this is what the CDC said, that 30% of Black women shared that they experienced mistreatment, followed by Latinx and multiracial. And it's important to note by insurance type. I was an L&D nurse caring for the birthing community for about 13 years before I moved into leadership and other roles. And I have to tell you, there was never a time that I was caring for a patient that I needed to know their insurance. That was never relevant to the care that I was providing. But it's important to note that there's a differentiation as it relates to insurance, and that those who did have insurance experienced more mistreatment. And I hate that. I think it's deplorable, and I don't think it should ever happen. So this piece of the report really impacted me in a significant way, which is why I wanted to call it out. Again, they said 1 in 5, but if you look like me, it's 1 in 3. But it's the third thing that really, really bothers me, because almost half of the women that were part of this study really held back from sharing a concern about what was happening with them, with their pregnancy, with their bodies, maybe with their babies. Almost half of the people refrained from saying something. And I think it speaks to not creating the psychological safety that we need to create for this patient population, for this group of people. Maybe it's the pace. We're moving so fast and folks don't think that they have enough time. I know when I go see the doctor, I'm like very strategic in using my time, right? But that's worrisome because if we don't know what's happening with our patients, the likelihood that something could go awry is pretty significant. And we talk about data a lot, right? It's a gap QC, it's what we do nowadays. But sometimes it's important to know the stories behind the data. The data is compelling. The data moves a lot of people. But I think stories are really important. This is in the voice of a patient in the Giving Voice to Mother study. She said, I hated being shouted and lied to by the midwife. I never dreamed that a woman could treat a laboring woman that way. She was abusive and downright mean. I was refused food and water for 26 hours. I wasn't allowed to move out of bed to walk around. I felt like I lost my autonomy over my own body. I had given up, and I remember weeping when my son was born. I was at least glad that he was safe. I felt like a child. I felt so unlike my usual self. These professionals broke my spirit. So this is our current reality as it relates to the care of the birthing community, nothing that we're proud of. As we continue to level set, I want to call out bias and racism as a significant contributor to the issues that we're facing with morbidity and mortality. Bias and racism. Significant contribution. We're not going to talk about racism because I have so much that I have to share with you, but I wanted to call out just a couple of things as it relates to bias. If you've heard me speak before, you've seen the slide, but this is a small meta-analysis of about 40 articles. And the question that was posed by the authors was, I wonder if healthcare providers, clinicians, practitioners have the same level of implicit bias as the general population. And the answer is yes, based on the data. The answer is yes. As you're looking at the circles, if we start from the left, there's a higher degree of bias associated with the left, and it decreases as you move towards the right. So race and ethnicity, we're more biased about things that we can see. The things that we can't see, we can't judge because we can't see, right? So it's important to know that that is an issue. And also, here's a great definition of implicit bias. Explicit bias is racism. We know how we feel about certain races, so that's top of mind. But it's important to note with implicit bias, it's unconscious. It's not top of mind, right? But it's important to note that it influences our decision making, it influences our judgment, it influences how we interact with people. So it's super important for us to know what our biases are as we care for people during such an important part of life, which is pregnancy, labor, birth, postpartum, and the fourth trimester. As we consider the whole concept of equity, you've seen several different images of equity. I really love this one. So equality, we know, is giving everybody the same thing. And I always say that the assumption of equality is that everybody's starting from the same vantage point, and we know that's not true, right? We know that's not true. As you look at the graphic below of equity, if you look on top, equality, if we give everybody the same thing, it only works for one person. If you look at equity, giving people what they need, then that makes a lot more sense. So when you consider equity, there's going to be an initial cost associated with it, right? I would imagine that for this person who was mobility challenged, that what she needed to help her to be mobile cost more money than what the others depicted in this graphic shows. There's a cost associated with equity in the front. But as we consider the downstream impact, I think that's really important to call out. So for somebody who had no mobility, could not go out and go shopping for food or for equipment, supplies, whatever was needed, could not go out and work. That's a significant limitation. But once somebody is able to go out and purchase their own food and have a job and have the resources they need, then they become a productive, what we define as a productive member of society. We foster independence. So the benefit far outweigh that initial cost of equity. So I'm not saying that equity doesn't cost, but I'm saying that the cost is nominal when you look at it over a period of time, over a spectrum. I love the Institute for Perinatal Quality Improvement, the graphic that they use, because this really resembles the patients that we care for. So again, equality is giving everybody the same thing. And what I love about this equality graphic is if you look to the left, there's like a bunch of boxes just chilling in the corner. And it speaks to our scarcity mindset. In the United States, we have this scarcity mindset when we're actually living in abundance, right? But with a scarcity mindset, our likelihood of ensuring that everybody has what their needs is difficult because you're like, wait a minute, even though nobody's using it now, somebody may be using it at some point, and we have to keep it here just in case, right? And that's the mindset. I use the example of shoes. You know, I've asked many audiences and friends, do you know how many pairs of shoes you have? I mean, I can't see the chat, but Amy can see it. I would love if anybody in this group knew how many shoes. I don't know how many pairs of shoes that I have. And let's say somebody comes, I'll give you my example. If somebody came to a closet, because I have shoes in more than one closet, and took out 3 pairs of shoes, I probably would not know nor miss it. Maybe ever, or maybe in some period of time. It's important for us to really change our mindset to consider, hey, how can we level the playing field for everybody so that everyone would be successful? I love the definition that Dr. Joya Kriya-Perry penned in 2019, that equity, and I put birth in parentheses, she did it for birth equity, but equity is the assurance of conditions that are optimal for all people. However, we need to address racial and social inequities in a sustained effort. We understand that bias and racism significantly, totally plays a role as we consider equity. So it's important to call that out. And I love that definition. So that's our current reality. And now I want to talk more about the QI tools. And I'm going to preface this by saying, and I've said this before, and my friends on the call will love me and support me, knowing that I am not a researcher, right? That is not my jam. I love the abstract. I love the results, you know, and some of the graphs that I really love, but I wouldn't define myself as a researcher. So it's interesting that I'm going to talk about QI tools, but here we go. So this is the one, and I think Jennifer alluded to this earlier in her introduction. By the way, welcome. But PDSA, we are very familiar with the Plan, Do, Study Act. And I love the clarifying questions on top because it helps. I'm really great at asking questions. So if that makes me a researcher, then I'll take it. So what are we trying to accomplish, right? We need to be clear about what are our goals. And then the second really great question is, how will we know that a change is an improvement? Because we know that not every change is an improvement, right? And what change can we make that will result in improvement? So I love those questions. And I'm curious about you and your experiences. Have you ever, in your professional life, been in a situation where you made a really big change, like a really big change that cost like millions of dollars, and there was like a big marketing campaign around it, and the community knew you were going to do this change, and then it didn't work? Has that ever happened to anyone? I'd love for you to put that in the chat. I can't see the chat. but I'd love for you to put it in the chat. And if Amy sees something, she promised me she was going to share it with me. What do you do when that happens? What do you do when you have done this change and you don't have the results that you need to have? I'm going to read something to you from 1991. Are you ready? This is a quote from a study. It said that randomized clinical trials of the past 10 years have compared electronic monitoring to routine periodic auscultation, so intermittent auscultation, and have consistently failed to demonstrate a statistically significant difference in either the perinatal mortality rate or the outcome for the high-risk pregnancy. 1991, talking about fetal monitoring, which many of us in many of our organizations would call that like the gold standard. Fetal monitoring is the gold standard. But we haven't been able to prove that with data, right? And this is really a topic that I'm sure many of you are like really tightening and clenching your fist now, like, oh, what is she talking about? I'm talking about the value of looking at QI tools and looking at data and ensuring that the data supports why we're making the change and understanding that not all changes result in improvement. And when they don't, do we have the courage? Do we have the vulnerability to say, yikes, this isn't working? In my research of looking at QI tools, I came across this. And as soon as I saw it, I loved it. And I said, I have to share this with the GAP QC folk. This is from the Institute of Healthcare Improvement. And they're talking about culture and learning. And I think it's really important as you look at the orange, that's the culture and the learning system. It's really important that the two have the overlap and have that congruency. This is a framework for safe, reliable, and effective care. And they talk about the 9 interrelated components. What I love so many things about this. One of the things that I really love is that it centers the patients and the family. I think that's really important, even though you don't see the word equity anywhere in here, but the fact that it centers patient and family speaks to equity. Some other words that really speaks to equity is psychological safety. Understanding that it's not just about the data, it's not about the measurement, it's about that emotional piece, which is creating psychological safety. And then next to that is my personal favorite word is accountability. We know that accountability is super important for any initiative that requires change, right? You need that accountability piece of it. I love the teamwork and communication negotiation. Continuous learning. We know that there is no destination as it relates to learning. That is a journey. It's a lifelong journey, and we're on it until we die. I know all of us are. We're going to learn something new until we die. Improvement and measurements is important. Reliability, we kind of spoke about that a little bit in the PDSA one. And then transparency is another really great tenet that leads to equity, because transparency just speaks to the fact that we're sharing everything broadly. We're disseminating information broadly. And hopefully in that transparency, we're also stratifying some of our data. And leadership is definitely important in that. But I just love this. And I think this is something that a framework that we can really look to as we want to consider equity in the work that we do. And in my research, I came across this. Number one, I loved it because it was visually appealing. And number two, I really liked it because they were able to call out equity immediately. So this is CMS National Quality Goals. I love the graphic with the people in the center. Again, we're going to center the voices and choices of people. I love that they were intentional in reflecting that we don't all look the same. We're not the same age, the same gender. We don't have the same mobility. I think that is really great. And then you have the 8 strategic goals, with equity being called out right away. And I love that. That's really important. Advancing health equity in a whole person care. It's important for us to not be just diagnosis focused, but approach from a holistic perspective, because that's how change happens. It happens holistically. It doesn't happen individually. They go on to call out the importance of engagement, of safety, of resilience. And of course, we want the outcomes, right? Because we need something to measure against. The alignment is important. It had it in the previous framework that we're aligning culture and the learning system. Um, Interoperability is super important in the digital world that we live in. We need to make sure that our IT systems, our digital systems are really driving that so that it's easy to use. So no matter where the patient is getting care, we can see this information immediately, and that the patient will have access to it. And then the scientific advancement, that's important as well. They said in this article where I found this beautiful graphic that success lies on these three call to action. They said they have three quality calls to action. I'm going to read them to you. Number one, they said to prioritize use of universal foundation measures. So make sure that it's universal and that it measures everything that's important. Number two, they said commit to improving healthcare safety and the reduction of harm. And you see that in the safety and the preventable harm. And number three, they said advance health equity to improve health outcomes and eliminate disparities. So again, this is their three big strategic goals at CMS, and equity is at the center of that. So as we consider best practices and folks who are really calling out the importance and the value of equity, I thought CMS was a great example. So this is the National Quality Strategy Goals. Now I'm going to share this with you because CMS, evidently in my research, are doing a really great job. So we're going to highlight those who are doing a great job. So this is the CMS strategic plan. And again, you'll see that advancing equity is one of their first plans. And they have a definition of equity that I really love, and I want to share it with you. They said it's the attainment of the highest level of health for all people, where everyone has a fair and just opportunity to obtain optimal health. So all of us deserve optimal health. Doesn't matter race, ethnicity, ability or disability, sexual orientation, gender, all of the things. It doesn't matter. We all deserve optimal health. And I love that definition. It was in their data from 2023. And if you go to the CMS site, they have their list of clinical standards and quality. And these are ways for healthcare organizations to get additional points for reimbursement for the work that they're doing within the healthcare organizations. And what they're calling for is an equity-focused measures in all settings. So it's very timely for us to have this equity conversation, equity-focused measures in all settings. So as you're doing your PDSA, are you factoring equity? Are you making sure that you're considering the barriers for some people that may be even woven into your QI tools or into a research that you may be doing? I think all of us have heard about the birthing friendly designation. We'll talk about that in a moment. Again, looking at quality improvement resources to populations who have the greatest disparities. If you're putting together a research team, it would be super helpful for your research team to resemble the demographic that you're going to be researching, right? Because we know that the lived experience really matters. So you don't want a homogeneous group of researchers. There needs to be intentionality. If you want to do this research and you know there's certain people you always tap on. I know there's people that I tap on, people who love the data, people who are great at project management, people who are great at asking, good questions, but there needs to be intentionality to ensure that there's representation in your team. Because again, the lived experience is going to matter as you start your research project, right? And then also to propose and reward excellent care for underserved populations. That is a goal of the CMS. How do we reward people for doing their work and for having that intentionality and focusing on those who are resource poor. So the birthing friendly designation just came to play like about a year ago now. And the focus is on a couple of making sure that hospitals can get this designation if they're abiding or implementing a couple of the AIMS bundle. I think the recommendation is around the postpartum hemorrhage bundle or the hypertensive crisis bundle. And what I love about this is that, again, it's more of the transparency of data. Because all of the information is going to be on the Care Compare site. So we want to make sure that if you want to be a birthing friendly designated hospital, that we know that you're looking at quality improvement, you're looking at process and structure changes, you're looking at outcomes. And not only are you looking at outcomes, you're making sure that you're looking at stratified outcomes. Aggregate outcomes will tell you one story, but if you want the truth, you really need to look at stratified outcomes. And that's what the birthing friendly designation will definitely help to do. And it weaves in accountability. If you look at the bottom where it talks about impact and it talks about holding hospital leadership accountable. And we know that the leaders are not doing all the work, right? Because the leaders can't do the work. So the leaders have to create that compelling vision. We have to be able to say to our teams and to those who report up to us why it's super important for our work to reflect equity and do it with such compassion and make it so compelling that everyone is on board and will say, oh my gosh, that makes perfect sense. I'm going to totally do this every time. So that accountability, again, my favorite word, is really important, because if you want change, you need to have that to have change. When I was at Emory Decatur Hospital, we were significantly galvanized by this bundle. This really started us on that journey towards equity. We had been having conversations and we had been doing journal club reviews. And when we discovered the importance of looking at disaggregate data, this was really a wonderful tool, a wonderful map for us to get us on that path. I would say it's super important for you if you're in a hospital, a healthcare setting. It's really important for you to look at your data. Look at the data that you're already sharing to the regulatory bodies, that you're sharing to Joint Commission. So look at your breastfeeding rate, look at your C-section rate, look at your inductions, look at all of those, BSIs, everything that you're sharing. I think it's super important to look at that stratified so that you can ensure that there is equity, right? Because if your aggregate data shows that you're trending in the right direction, and then when you begin to look at it by race or ethnicity, even though we know that race is a social construct, but it is a social construct that we as Americans have really latched onto. So if you look at race, if you look at ethnicity, look at language. We were really surprised when we started looking at our data and stratifying for language. Look at the patient experience. That's a really fascinating one. What is your patient experience for your white patients versus your Black patients versus your Latina patients? It's really, really important to look at all of that. I will tell you, we had a very interesting finding as it relates to outcomes for patients that had public insurance, versus private insurance, because there was a lot of assumptions made that patients who are in Medicaid were high-risk patients. So for another day, I don't have time for it. Invite me back and we'll talk about that. And what we found out, did not quite match the assumptions that we were making about patients who had Medicaid as their insurance. But anywho, this was really helpful. I love what Dr. McLemore wrote in her article about dismantling structural racism. She said that nurses are uniquely positioned and uniquely qualified to lead health equity efforts. And I know it's not just nurses on this call. It doesn't mean that we're excluding anyone else. But she said that the power in nursing exists in our code of ethics, and it exists in our QI tools, our bundles, our toolkits, and our strategies. But she also says it's important for us to partner with impacted communities. So don't forget to pull the communities in. Don't forget to be intentional to say, hey, we want to really impact change in our organization so that, we're using the lens of equity and so that our outcomes are equitable. We want you to be part of this conversation. Will you help us? The community will say yes. So in 2017, I coined this hashtag because I was, as you heard in the intro, I was super frustrated at our rising rates of morbidity and mortality. And I was like, geez, oh man, what can I do? And Not on My Watch popped on my head. And it really became a call to action. And it's now my life's work because I know that with intentionality that we as nurses could really, really mitigate the rate of morbidity and mortality. We can. These are the 5 tenets of Not on My Watch. Number 1, that we treat everybody with dignity and respect. You'll see that the word equity is not here at all. But if you do these 5 things, it leads to equitable outcomes. That we listen to and believe. So not just listen to, listen is passive, believe is more active. I believe you and I'm going to take action. That we engage in shared decision making. We don't create a hierarchy where like the provider's at the top and the patient's somewhere at the bottom. No, we center the voice of the patient and we make decisions with, not for the patients. We're scientists, so we believe in evidence-based care. And we advocate. I'm hearing some feedback. Maybe somebody needs to mute. And we advocate for women and birthing people. So here are some solutions to help us to move towards equity and to utilize the lens of equity. I love CDC's Hear Her campaign. I'm sure you are familiar with the Hear Her campaign. At the hospital, we use the A1 post-birth warning signs. And CDC came up with urgent warning signs, which you'll see that's captured here as well. And I think it's really wonderful to have this information to give to women and birthing people to inform them. But listen, this is only as good as our willingness to believe them. So when they are complaining about this, any of these signs and symptoms within a year, not just 6 weeks, 12 weeks, 6 months, within a year post-birth, we need to definitely listen and believe them. And then I'm going to hurriedly just end with our language. Our language matters. Remember, as kids, we used to say, sticks and stones will break my bones, but words will never. Yeah, that's a big old lie. We know that words are incredibly harmful, that words are traumatic, and that words can definitely cause harm. So it's important for us to remember that. You're probably all familiar with the power privilege wheel, right? The closer you are to the center of the wheel, the more power and privilege you are. So if I was a white, cisgender, thin, wealthy, married woman or man, I would have a ton of power and privilege. But if you're in the margins, I'm a dark skin, trans, large, maybe unemployed, and maybe English is not my first language. English is not my first language. I would be on the margins, right? And we treat people in the margins differently. We speak to them differently. And we need to remember this power privilege wheel and be intentional as we engage in people. So I was very excited to be part of this article that was posted in the Green Journal in October of last year. OB and GYN has a fair amount of misogyny woven into it historically, y'all. I think you know this, but in case you don't, there's a fair amount of misogyny in OB/GYN, and it ekes out in our language as well because the terms we come up with are just, yeah, bad. So look at some of the terms we use: fail, fail, fail. Oh, geriatric pregnancy, I love that one. Or non-compliant. So we listed some of the commonly used stigmatizing language and some other options to use. I remember looking at HNPs, and it's like a 41-year-old Black married woman. I don't know why married is important. I don't know why race is important. So if you come down to the bottom where it says inclusion of race and ethnicity on the left side, we need to acknowledge racism as the risk factor. Race and ethnicity are not biological risk factors for adverse outcomes and should be avoided in our documentation. This is from the CDC, and I love it also for you to look at, okay, what can healthcare systems do? What can providers do? What can everyone do? So healthcare systems, training is really important on unconscious bias, training on respect, including people like doulas and midwives. We need more midwives. We need more midwives, y'all. The midwifery model of care has been proven for decades that the outcomes are simply wonderful and better than other outcomes, right? Look in the middle. Everywhere you see listen, I want you to say listen and believe. So don't just listen to your patients and ask questions. Believe them when they say what they're saying. Recognize your unconscious bias as a provider. Use the urgent maternal warning sign. And then you'll see for everyone the recommendations that everyone can do. Listen to second bullet point and believe. That's super important. All right, I'm just going to run through this because I am almost out of time. So I want to say in conclusion, or as we commit to using an equity lens, as you commit to doing your QI work, make sure you use an equity lens. Make sure you recognize that not every change leads to improvement, and be courageous enough to say, this isn't working for us. Let's scrap it and start all over again because we don't want to contribute to harm, right? That's really important. And I'm going to leave you with some quotes that I really, really love. JFK is purported to have said, a rising tide lifts all boats. And I call this out because oftentimes when we are intentional in putting something in place for a marginalized community, there may be resentment. Oh, why don't we do it for everyone? Well, probably because everyone is not dying at the same rate. But the truth of the matter is, when you improve for one group, you improve for everyone else. And that's important. I love this quote from Deadly Delivery, Amnesty International, where Lee John Wook said that mothers and newborn and children represent the well-being of a society and its potential future. What does the fact that 80% of maternal morbidity and mortality is preventable, what does that say about our society? I just want you to think about that for a second. And then last but not least, I love Dr. Martin Luther King's this quote that he says, we are caught in an inescapable network of mutuality, tied in a single garment of destiny. What affects one directly affects all of us indirectly. So using an equity lens benefits everyone. I guarantee that for you. I have references that Amy has access to my slide deck, and I don't think we have time for Q&A, but you can put it in there and I'll be sure to respond to it. If you want to connect with me and tell me your own stories, I'd be delighted to hear your stories. And it's 2:59, y'all. So I'm going to go ahead and stop with that and turn it back over to Amy. I'm going to stop sharing as soon as I can find that.
So thank you, Rose, so very, very much. This was an excellent presentation, and we're getting comments as to that in the chat. Just one quick comment was, if something doesn't yield the results I wanted, I usually tried to work to identify what the challenge or barrier was in order to identify what changes are necessary. And then just wonderful presentation. Thank you so much, Rose. This was spectacular. Thank you so much. So
Yeah.
grateful for this. We will post this information onto our website. Just give us a few days to get that on there. If there are additional questions for Rose, feel free to send those to Georgia GAPQC@dph.ga.gov. We'll get those over to Rose, get an answer for you, and get those sent back to you with the answer. So again, thank you so very much, Rose, for this wonderful presentation. Thank you all for joining us. Thank you for the work that you do every day, and have a wonderful afternoon. Look forward to seeing you in June for the next webinar. Have a great day.
Bye, everyone.